So we're closing out another quarter of virtual seminars with Dr. Jessica Jerome from the Health Sciences. Dr. Jerome earned her PhD in cultural anthropology from the University of Chicago in 2003 and joined the DePaul faculty in 2012, and she's currently an associate professor in health sciences. Her research focuses on healthcare and urban healthcare reform and access to healthcare. In 2015, she received a Fulbright fellowship to study healthcare councils in Brazil. And in 2018, she served as a visiting scholar at the Berkeley Institute for Urban and Regional Development. And she's also the author of A Right to Health, Medicine, Marginality, and Healthcare Reform in Northeastern Brazil. So she's going to talk to us today a bit about the COVID vaccination campaign in Brazil. And with that, I'll hand it over to Dr. Jerome.
Okay, thank you. Thanks for that nice introduction. And I think, you know, you guys have heard and you can read here a little bit more about me. I think the thing that I want to emphasize is, my primary research site is in Brazil. It's in Northeastern Brazil, and I primarily use qualitative methodologies. So in the past, I've done participant observation, which is kind of longitudinal research, longer term field visits. I've actually followed the same population group over about a 20-year period now. But the one thing I would add to that is I have not been back to my research site for quite a while now. I mean, I hadn't been for about a year before COVID, and I haven't, you know, obviously been able to go back since. So I don't have a lot of qualitative research to share with you today. I just wanted to put that out as like a spoiler alert. I'm hoping, you know, in the coming years or coming months, maybe even, to be able to do some of that work. I think there'll be a lot of interesting things to understand. But for right now, I'm actually going to focus my talk on something that I spoke about in a panel that our department did on COVID. So I'm going to look at what some of the global inequalities are in COVID vaccine distribution. I'm really going to be focusing on vaccine distribution and not talk about the equally important, you know, and also inequalities that exist just within COVID itself, morbidity and mortality there. In order to do that, and then I will use Brazil as kind of a case study to look at what vaccine distribution thus far has looked like in that country and what some of the problems are there. I did want to start just by reviewing global health inequalities more generally, because I think it provides a good framework for sort of situating the kinds of inequalities that we see with regard to vaccine distribution. And I think what will probably become apparent is just the pattern of inequalities that we see. Those are really evident when you look at some of the more well-known inequalities in global health. So I was trying to think about this. I actually teach a class in global health, and we spent a lot of time talking about, you know, inequalities within global health. And so I was trying to pare it back and only share some of them. So I just wanted to draw your attention to, when people think about you know, the kind of metrics that we use for global health, the things we care about, and the things that might stand out as being unequal when we look around the world with, you know, looking at various health outcomes. The things that we tend to think about or that come to mind first are a distribution in preventable diseases. These are largely infectious diseases. So things like pneumonia, diarrhea, malaria, tuberculosis, all of these preventable diseases, we see much higher rates in what I'm going to call resource poor countries. I'll define what I mean by a resource poor country in just a second, but let me leave it at that kind of very generic general level. So distribution of preventable diseases, there are large inequalities. Life expectancy, this is a big one that, you know, you'll hear lots of numbers flying around about this. If you look at some of the wealthier countries, typically life expectancy is somewhere between 80 and 85. It kind of depends on the country. And that starts to go down in the poorest country to being in the early 50s. So there's really a large gap there in terms of life expectancy. And then the third thing that I was going to mention is just access to healthcare facilities. And I did want to just give you some idea of how do we measure that? How do we talk about that? I found, there are lots of figures you can look at online. I found this table pretty helpful because it gives specific metrics. So if you guys look at this yellow box, I'll just leave the slide here for a second so you can take a look at it. I think it does a good job of illustrating the problem and of really illustrating those gaps. So here we're looking at hospital beds. That's usually measured per 10,000, number of 10,000 population. Doctors and nurses get measured per 1,000. But, and then here we actually have countries broken out. I've been using terms wealthy versus poor. Here we have, it's a little finer gradations. You have the poorest countries, low income, high income countries, of course that would include a country like the United States. And you just see, it's so stark, these disparities. So looking just, for example, at hospital beds, 9 per 10,000 versus 57. I think something like nurses is even more stark where, there's less than 1 per 1,000 nurses in a low income country and then more than 8 in high income. So it just gives you some sense of the kind of real disparities that we're talking about. I also thought it might be useful just to look at one specific healthcare outcome. So something like infant mortality is often used as a kind of metric or stand-in just for the health of the population as a whole. And if you look at the infant mortality rate around the world, you see, you'll see a pattern that's going to look very familiar when we come back to the global distribution of vaccines. But you can see it, again, there's quite a large gap. So in the wealthier countries and in the countries with much lower infant mortality, you're looking at about, under 10 per 1,000. And just really briefly, the way infant mortality is measured is you're looking at all live births. So from the time of birth, stillborn babies don't count, but live births until 1 year of age. And it's just counting out of 1,000 how many of those babies pass away during that time period. So you get under 10, and then in countries where it's really extreme, it is more than 120. So again, really large gaps there. That's not what I want to do. Okay. Oh, I thought I would throw this in because I'm going to be talking about Brazil. And I did want to point out, somebody could say, well, you're talking in the aggregate, and surely some of these countries, that are poor, they're not all poor. Maybe in their cities, the rates are going to look better. And that would be a very good point. So, if you look at a country like Brazil, this is actually Brazil, I guess it's on your right, and it's just divided up into the states in Brazil. And you can see that, even within Brazil, you get these large disparities. So I think, I can't tell what you guys can see and what I can see, but I think I have an arrow there which shows the state that I work in, which is Ceará, which is up in the Northeast. And it is the northeast of that country tends to be poorer than the south of the country, and the rates in fact are higher there. So, okay. So I thought before moving on to looking at vaccine distribution, we could think about why. You might ask these questions, why do we see such persistent inequalities in these global health outcomes? And that is not a question that I can answer. Certainly not in a lecture like this. I try to do some of this in the course of a quarter, and it's challenging. But I guess the thing that I wanted to emphasize with the kind of explanations that I have up here is that they are, I think the explanations for the kinds of inequalities we see, and this is also going to be true with regard to vaccine distribution, are structural, they're historical, and they're deeply embedded, even in the way that we've organized our world. So actually, I was thinking about something like nationalism. I'm just going to call that out. And this will actually come up when we start talking about the way people have thought about global vaccine distribution. And it's a fact that our world is organized into these nation states, and that in general, it's harder to get nation states to think about the interests of the global community than it is to get them to think about their own self-interest. And that is true with regard to global health problems as well. Now, certainly there are some global health bodies and global institutions. The World Health Organization is, of course, I think a great example of this, which I think one of its primary functions is really to get us to move outside of our, individual national concerns and get us to think about ourselves as a global body. But I would say that's a kind of developing consciousness, and it's something that still needs work. So we can come back to some of these issues later, but mainly this slide is just to emphasize how deep and complicated the kind of, I guess, explanations are for these kind of global health inequalities. Okay, so let's turn now to looking at global COVID vaccine distribution. It is the case that the very exciting news in the United States. I really celebrate everybody who has gotten access to a vaccine. I think, I was just listening to President Biden's speech last night, and he made clear that at least there's this expectation that all adults will have the opportunity to be vaccinated by April 1st, May 1st, sorry, not April 1st, May 1st, which I think is, of course, remarkable and just fantastic. But most of the world's population right now do not have adequate access to the vaccine. And the expectation is that although that is changing, it could be years before everyone around the world has access to it. So the thing I'm going to focus on today is looking at some of the patterns in those inequalities, and then trying to understand what the response to that has done. What are we trying to do to reduce those inequalities? And I think there's some exciting news about that, which is great. So there's a pattern to these inequalities in vaccine distribution, and that pattern is one that I was just presenting on. So it's probably not shocking to anyone. Richer countries, more developed countries, more economically developed countries have more vaccine than poorer countries do. The poorest countries have no vaccine. So there's one point that I wanted to make before going into more of the details about this vaccine distribution. So, and yeah, I guess I was like, well, maybe I should have done this before I started talking about global health inequities more generally. But I think it's important. I always forget, I always have to be reminded, and I think this might be true for others as well, how much of the world's population is poor, how much of the world's population actually resides in what we would call a less developed country. So getting back to that question of, what's a wealthy country, what's a poor country, there are different metrics for that, and people argue about how to define that exactly. But I think one, just kind of easy way to define that is in terms of earnings. An individual in a country, how much are they earning per year? So for many of these organizations like the WHO or the World Bank, et cetera, if you are a country that is earning, an individual in a country that is earning less, the average earnings, like the per capita earnings of that country as an individual, less than $12,000 a year, you count as a less developed country. If you're earning more than that, you count as a more developed country. So anything, I just find this amazing. I actually had to look it up on several different sites in several different ways because I couldn't believe that figure was so low. I mean, obviously cost of living really varies throughout the world, but I think it's a really striking statement about how little wealth it takes to be considered a wealthy country. And, so I've tried these figures that I'm showing you here. I guess on the right, this is a picture of the globe by just by population density. So showing you where the bulk of the people reside. You know, it's as though well, India is of course very blown up because India is so populated. So you can look around, you know, the United States takes up less room because compared to the rest of the world, it has less population. So I guess I was hoping that that map would give you a more visual sense of where the bulk of the world's population is located. And then on the left here, I think that it's, you know, you can tell, I guess, how persistent this division in countries has been. It's actually that that kind of split between less developed countries and more developed countries is actually growing over time. So as time goes on, more of the world's population is located, defined as living in a less developed country. And you can see that the population density for those more developed countries is actually remaining fairly static over time. It's, you know, it's growing a tiny bit, but not by very much. So what that means is all those healthcare inequalities that I was telling you about before, not only are they worse, you know, not only are the disparities there, but it also means that, you know, when I present something like hospital beds in these low-income countries and how few they have, it means that most of the world's population is experiencing that kind of limited access to healthcare. So I think that's important because it, you know, it could be the case that yes, in low-income countries you only experienced a little bit of access to healthcare, but maybe there are not very many people residing in low-income countries, so that's a relatively easy problem to solve. But that turns out not to be the case. Instead, most of the world's population is residing in countries where healthcare is harder to access. So it just, you know, I think it helps make sense of some of these disparities that we are now going to look at in vaccine access. Okay, so let me turn to these 2 points that I have up on the slide here. So I'm looking at early March. Rich countries, and again, you know, I'm just going to point to this kind of dark blue part of the slide, make up 15% of the world's population and have bought up more than 50% of the vaccines. So that's kind of the distribution where we stand right now. And just as a starting point to be able to discuss this, I think it is important to realize that when the COVID vaccine was first being produced, it was thought about as a private resource, something that private companies would produce and that then would be purchased by countries and organizations around the world. So, you know, from the beginning, this is something that has not been conceptualized as kind of a global public good. And I think that has initially really structured the dynamics of COVID vaccine distribution. I think this slide is useful because, or the figure here is useful because it shows a tactic that that countries were using in order to get access to COVID vaccine before it had even, you know, been produced and before it had received regulatory approval. So if you look at this, you can see the amount of pre-orders that these countries were doing. You know, again, this is before there was widespread distribution of the vaccine, and you can look at it as a percentage of their population. So there are these very high income countries like Canada and the United States, European Union, who were already, and you know, this is back in the summer in 2020, they're thinking ahead and they're thinking about wanting to protect their population and getting their orders in early. And like in the case of Canada, you know, they're ordering significantly more vaccine than their population is. If you go down to poorer countries, they are either not ordering any COVID vaccine at all, they're not able to make those kinds of financial commitments, or they are ordering, you know, just a small portion of their population. So I given that facet, or yeah, I guess given that fact of the way that, the fact that the COVID vaccine was conceptualized as a private good, the fact that a lot of these rich countries immediately put in a bunch of orders for them. And, I would say low-income countries, the lowest income countries, probably from the beginning recognized that this was going to be a problem. And it wasn't just the countries themselves. The World Health Organization was certainly thinking about this, already aware. I'll come to this in just a second, but already aware in the first couple months of the pandemic that they were really going to have to get on top of this, and they were going to have to take steps in order to ensure some kind of access for the poorest countries in our world. So then, I wanted to think about, well, what are some of the options for these lower income countries? How can they respond to this situation where, just historically, healthcare outcomes have been so unequal? We have this emerging infectious disease, which in some sense is a leveler in the sense that it's impacting everyone. It's infecting everyone, right? It's not respondent to wealth. Well, I shouldn't say that. It is respondent to wealth and poverty, but it is at least at kind of a general level, it's something that people can't immediately protect themselves from, say, in a way that now in the United States, if wealthier populations have become very good at protecting themselves, say, from infant mortality, right? But this is this kind of new emerging thing. So what do low-income countries do about this? And the first thing that has kind of happened is that there have been protests and these protests have taken a very politicized form. So, and they're following a kind of historical process that has been used for this before. India and South Africa were two countries that in October of 2020 went to some of the WTO's, the World Trade Organization meetings, and said, we need to waive patent rights on these pharmaceuticals. And they actually asked not just to waive patent rights on the vaccine, but for all COVID-related products. And I think they thought when they did that they could actually make a pretty compelling case for this. This is a global pandemic. Surely everybody should, have an interest in this. I think people are really, starting to recognize that we can't just stop this problem. We can't stop the spread of COVID in one country and, guarantee that we're never going to get it again because of the, just such increased globalization in our world. So I think they thought they had a relatively compelling argument going forward, and they were just completely shut down. So European Union, Canada, United States, actually Brazil as well. There were a number of countries, most of them, the wealthier countries, opposed the proposal and shot it down. The countries, I think, so I want to introduce another idea. So on the one hand, I think they were really asking at that moment of, proposing this, that that vaccine and those COVID-related products be thought about as a public good, really as a global good, something that belonged to the global community, as opposed to a private resource. And the other thing that I think is important in terms of conceptualization is that they're introducing this idea of thinking about health and healthcare as a right rather than a commodity. So the way that these COVID vaccines first came online, and it was just pharmaceutical companies are producing them, immediately it goes into the paradigm of this is a commodity. This is something that you have to buy. And if you have purchasing power, you'll have access to it. And if you don't, you won't. And I think that idea of protest and, trying to waive the patent rights, they weren't asking for long-standing waivers. Actually, they were doing it on a temporary basis. And that is really challenging that idea of thinking about healthcare and healthcare products as a commodity. So that was one of the first things that was done, or one of the ideas that was tried in order to get low-income countries access to the vaccine. It was, just checking the time, okay, it's not successful. So what are the other options? And I would suggest that the primary other option right now is an alliance, a partnership, which I'm going to refer to as Kovacs. So Kovacs is kind of a complicated mechanism, and I'll have a couple slides here to describe it. I can try to answer questions after I'm done with the talk. But it's, it's this new emerging entity, and I'm certainly not an expert in it. So what I can tell you is that there was a partnership that was started back in 2020, April of 2020. I think it's totally remarkable. It's such foresight. This is only like a month after back in March, when the World Health Organization declared COVID actually a global pandemic. And already in April, these organizations, global organizations, so you have this Global Vaccine Alliance, which is called Gavi, the World Health Organization, Bill and Melinda Gates Foundation, very large, famous philanthropic organization. They get together and they say, we're going to have to do something about this. We're going to have to form an alliance that at the very least gets money to provide vaccines to countries who are not going to be able to afford it themselves. So that is actually the piece of this broader Kovacs Alliance project, I guess I'll just call it, that was formed, and that is referred to as Gavi Kovacs ANC. And that specific piece of what is called the Kovacs Alliance is specifically designed to help the poorest countries, the countries that cannot self-finance their vaccine purchases at all. And if you are eligible, if you meet that criteria as a country, you apply to this partnership, to this entity. And the hope is that, that you will get vaccine back from that. So I think I have two more slides here. So let me just take a step back for a second and talk about the broader Kovacs Alliance, because I think both parts of it are kind of an interesting way of reconceptualizing maybe how we'll think about global vaccine delivery in the future, and I think they press on some of these global health inequalities more generally. So Kovacs Alliance, this thing that I was just talking about, is formed back in April of 2020. It describes itself as a global group that monitors the COVID vaccine landscape. And, I think what they were thinking back in April is that they knew that there were going to be a lot of companies that were going into production, ramping up production, trying, doing vaccine discovery work, trying to find a vaccine candidate that would work. And of course, at that time period, no one knew who to bet on. There were just a bunch of companies out there doing this work. So the goal of this group was really to be able to monitor that landscape, identify the most suitable candidates, and then provide money to work with manufacturers to get them into production, even in advance of regulatory approval. So to kind of really speed up the process. And in order to do that, they would collect funds from self-financing countries. So, this is important. It's kind of like, if you're the United States, we actually haven't done this yet, but some countries have, like countries in Europe. You donate, you're a participating country, you give your money, and then you're guaranteed a certain amount of COVID vaccine in return. And there are lots of regulations and rules about all of this, many of which I'm sure I don't understand completely, but I did understand that of the 78 countries that have signed up thus far, it's a rule that none of those countries, at least right now, can pull out more vaccine than will cover 20% of their population. And I just say that so that it's understood that it's not supposed to be where a country is getting all of their vaccine for all of their population. Instead, it's supposed to be like another mechanism in order for them to kind of guarantee I don't know, you might call it like a base level of vaccine. And I think there are a couple of things, at least in my understanding of this, that are important. So on the one hand, you know, by getting a bunch of countries together to do this, you're providing manufacturers with incentives because you're using that money that they're all giving you to give to these vaccine manufacturers. And you're also ensuring some kind of collective purchasing power so that these, you know, these companies will know, okay, I have these 78 countries online. And therefore they have a little more control over the price of it. Okay, I think I need to go a little faster. So yes, okay. I just talked about this. This is that small kind of subgroup of the Kovacs Alliance, which is designated only for those countries that cannot self-finance. Because remember, for most of this Kovacs Alliance, it is self-financing countries that are putting in the money. And, you know, then there are these group of middle and lower income countries that really can't afford to pay for the vaccine themselves. So it's a separate entity that they can apply for. They're using donations from countries around the world, also private and philanthropic donations. This specific piece of the Kovacs Alliance has raised about half of the money that it thinks it will need to be able to provide vaccines to everyone in these countries, 92 middle and lower income countries. So, you know, the main kind of advertisement that you hear over and over again from this Kovacs Alliance is that no one is safe until everyone is safe. They're really trying to remind people that we live in this global community, and maybe unlike some of these other global health inequalities that I was talking about at the beginning, infant mortality or life expectancy, there's a way in which, you know, perhaps unfortunately, those numbers, those inequities do not come back to haunt people in wealthier countries. They stay in the countries in which they are experienced. But something like COVID, I think we are becoming acutely aware that, you know, even the global economy is dependent upon fixing this problem, not just at home, but everywhere. This alliance was formed to try to do that. Okay, so just in the last bit of my talk, I'm going to take about 5 or so more minutes to talk about Brazil here. So this is a country I did research in, so I felt like I had to use this as an example. It's not, in some sense, maybe it's not the best case study because it's not one of these poor nations, you know, the lowest income countries. So for example, it would not, it could not apply, it would not be eligible for this kind of subgroup of the Kovacs Alliance that I was talking about. It is still considered a developing country as opposed to a developed country. So it would still, you know, it would be in that broad swath of countries that I showed you in that figure at the beginning. So what has its COVID vaccine distribution look like? And before I tell you about that, I think a really interesting thing about the case of Brazil is that their healthcare system, because of it being a developing country, was actually, I would say, uniquely positioned to excel at COVID vaccine distribution. So there's a lot to be said about their healthcare system. I'm just going to say 3 things that really set it apart from the healthcare system in the United States. So number 1, they have universal healthcare. So all of their citizens are guaranteed the right to healthcare, and this is actually a right that is embedded in their constitution. Also in their constitution, it's stated that it is the responsibility of the government to provide healthcare. So it's actually leaves open room for legal challenges if you're not getting access to the kind of healthcare that you think you deserve under the Constitution. Second thing that makes it really different is unlike in the United States, Brazil has a very long history of prioritizing preventive care rather than acute care. That shows up in a lot of different aspects of their healthcare system, but I think most relevant for something like vaccine distribution is the number of public healthcare local clinics that they have set up throughout their country. So virtually every county in Brazil and every neighborhood within those counties has its own, kind of low-level, first-tier, just public health clinic station. They call them outposts there. And the analogy I always use in teaching is that you could think of it as being like your local library or a post office. I mean, that's kind of how often they show up. So this is where people go to get vaccines, any other kind of vaccine. And I think just having a system like that in place is, so useful when you're trying to do something new, like vaccinate everybody for COVID. So that's already been in place. And then also that Brazil actually has a long history of excellence in vaccine delivery. If you look at, some of these figures just showing what percentage of the population is vaccinated with, various of the most common vaccines, Brazil is always one of the ones towards the top, definitely above the United States. So they had a lot of things in place that made them really good candidate for being able to do, pretty good COVID vaccine distribution. That has not been the way it's played out in Brazil. And so in order to talk about why that is, so one of the things, people might have been following this in the press, but Brazil actually has the third highest absolute cases or deaths from COVID in the world. It's after the United States and India. That if you ask, ask around and read about who is responsible for that, it is not in fact the healthcare system. As I've just described, the healthcare system has a lot to recommend it. It should have been very good at both protecting people from COVID, should have been better than it was at least. And again, doing something like vaccine distribution should have been a fairly easy ask for a country set up the way Brazil is. But they have been dealing with a president there who, Jair Bolsonaro, who is, his response to COVID has been very much like our former President Trump's. He came into power in 2018, so, almost just before the pandemic took place. And he, like Trump, he really downplayed from the beginning the seriousness of the pandemic. He also, like Trump, caught COVID, so he's already had COVID, but he'd refused to wear a mask. He did not promote social distancing. He promoted a lot of unvalidated treatments. He has consistently denied requests for economic or health aid, consistently shot down governors or mayors who wanted to do more. I mean, his response, it's really been very cavalier and very, very similar to President Trump's. And Brazil has paid the price for that, both with regard to the morbidity and mortality they've suffered around COVID, but also with regard to vaccines. So if you look at what Brazil's response has been to vaccines more generally, Bolsonaro back in October, voted against lifting patent regulations, even though it would have benefited Brazil. He actually ended up focusing on a single manufacturer, the AstraZeneca, and that development ended up being delayed at the same time that was going on. So he wasn't getting this vaccine that he thought he was going to get. He was deriding the Chinese vaccine that Brazil had also had agreements with. So he was putting that down, saying that wasn't going to work. Turns out there's a political history to that. But yeah, he kind of put all his eggs in one basket, and he refused refused to ramp up and make agreements with his own pharmaceutical industry. So Brazil has this very well-developed pharmaceutical industry that could have kind of been out in front making agreements with some of these manufacturers like AstraZeneca, and he just now has started to make some of those agreements, and it looks like Brazil will be getting more shipments because of that. It is also now, Brazil refused at first to enter this Kovacs Alliance, but it finally did that. So it's going to enter that broader alliance that I was talking to you about, and apparently they put in enough in order to purchase supplies for about 10% of its population. So overall, I would say, the state that I work in, which is Ceará, I showed at the very beginning, it's up in the northeast of Brazil. It's a more rural and poor state. And just now, Brazilians over the age of 75 in that state, in the city of Fortaleza, so we're not talking about out in the, in the rural districts, but in the city of Fortaleza, are starting to get access to the vaccine. This is what, I'm just getting these reports from friends. But, for months, their hospitals have been clogged. It looks like the kind of stories that I would hear from there are similar to stories that you would hear come out of Texas, let's just say like a city like Houston, or maybe Los Angeles. So yeah, it has been a very unprofessional, I guess, response to both the COVID pandemic, but then also this vaccine rollout, certainly much slower and more chaotic. I think Brazil, we're going to see over time, I think they'll get their population vaccinated. So I'm not trying to make the argument that it's going to be like one of the poorest resource country. And I think that really is where our focus needs to be. But I guess the broader point here, at least my takeaway from this, is that leadership really matters. That, you can have this great healthcare system and, be completely kind of organized in such a way that would make vaccine distribution easy. And instead, because you have a leader, because your executive branch is, led by someone who does not believe in the virus, the entire country is frustrated because of that, and has a poorer result because of that. Okay, so just a few wrap-up points. I think one of the things we see when we look at the inequities in vaccine distribution globally is that it's really difficult to achieve all kinds of global health equity, and including vaccine delivery, when health and healthcare is understood as a commodity rather than a right. I think that the kind of vaccine development process and just how that happened really illustrates that idea that thinking about a healthcare resource as a commodity has such sharp consequences with regard to its distribution. I actually think I think the Kovacs Alliance is really interesting because of the way that it's starting to challenge those dynamics. And I do think, not only in this kind of subsector, which is going towards the lowest income countries, but I think even in this idea of pulling all countries together and using that in order to challenge the purchasing price, say, of the vaccines that are coming out of these private companies, I think that's an interesting way to challenge this older dynamic of thinking about healthcare resources as a commodity. So I'm excited to see how that grows. But I guess for me, Brazil is really just a potent reminder of how much leadership, and particularly executive leadership, matters within individual countries with regard to how the dynamics play out of the distribution within that country. And I guess I say that last bit as kind of a warning, because even if we got the global community together and we provided enough vaccines so that all of these income poor countries would have access to it, you still have to deliver that vaccine within the country. And anyway, I just think Brazil it shows you how much it can really matter who is in charge there. So I think I'll stop there, and I am happy to take questions to the extent that we have time for them. Thank you. Thank you. Hey, it's nice. I've never really seen that hand function. Anyway, thank you.
If anybody has questions, feel free to unmute.
Oh, I can put my chat up, but I don't know. But
I actually had a question.
yeah.
And I don't know if you necessarily will know this yet, but has Kovacs been able to start distributing the COVID-19 vaccine yet to some of these poorer countries?
Yeah, that's a good question. The last time I checked, I could not positively verify that they had. I couldn't find anything that told me yes for sure that they had. But this is the kind of area where I feel like somebody could say, no, there was a report just this morning say that they had. I think it is coming. But yeah, it's obviously lagging after others, but yeah.
Okay, thanks. So hopefully soon.
Hopefully soon, yeah.
Jessica, this is probably a long shot in the dark, but do you have any sense of, I know this is, I don't know, it's a loaded question, but vaccine hesitancy as it relates to leadership, you were kind of drawing parallels there. Do you want to broadly speculate?
Well, do you mean to the extent, like how important do I think leadership is with regard to vaccine hesitancy? Or,
sure.
Yeah, I mean, I think that's a huge issue. I think, so one of the things that I think Brazil has going for it, and that, and many countries have this, it's not just Brazil, but is that, they have a very extensive system of what are called community health agents. So that requires less training than, say, a nurse does. Typically it can be done with just a high school diploma. And also typically community health agents in Brazil, at least, tend to come from the communities in which the communities that they serve. And one of the advantages of that is that when you are being asked to get a vaccine by somebody from your community, there tends to be less hesitancy there. At least that's what they found. There are really high adherence rates in Brazil for vaccines. And I think that part of that has to do with their delivery system. And so I don't know. I mean, it's interesting because COVID is kind of the most contemporary example we have of leadership being specifically attached to a vaccine. Like, I can't think of, a politician coming out in favor opposed to the measles vaccine or something, right? So I guess I will be interested to see if Bolsonaro's, say, distaste of the, or just ridicule of COVID and of vaccinations will influence whether or not people are hesitant. I think it's possible. I guess I'm also hoping that once it kind of gets down into the community, people will trust the more local people that they're interacting with. So yeah, that's a start.
Any other questions for Dr. Jerome? Well, thank you very much for a very topical seminar. And
yeah,
we will definitely all be hoping to hear the good news. We hope your optimism is on target in terms of how well this Kovacs Alliance plays out.
me too. Okay, thank you. Thanks so much for coming near spring break and
Thanks
all,
again.
and happy spring break, everyone.
Yeah, and I'll be in touch again about seminars once we start up spring quarter. Our first seminar of the spring is going to be our new dean, Dr. Dance Barnes, and she will be giving a seminar on Friday, April 23rd. So keep that on your calendar.
Okay, great. Thank you.